Welcome. In the previous session, we discussed about ICE syndrome, which is one of the secondary angle closure glaucomas with a predominantly anterior pulling mechanism. In this session, we will be discussing the remaining two secondary angle closure glaucomas with a predominantly anterior pulling mechanism. Neovascular glaucoma, which is a very important topic, and epithelial and fibrous ingrowths. Neovascular glaucoma causes secondary angle closure glaucoma by an anterior pulling mechanism, and it is caused by development of a fibrovascular membrane over the iris and the anterior chamber angle. The fibrovascular membrane over the iris develops because of retinal ischemia, with the ischemic retina producing angiogenic factors, particularly vascular endothelial growth factor or VEGF. This fibrovascular membrane covers the trabecular meshwork and pulls the peripheral iris forwards against the trabecular meshwork. The most common cause of neovascular glaucoma are vascular diseases causing retinal ischemia. So in the predominant majority of neovascular glaucoma, posterior segment ischemia results in anterior segment neovascularization. And the vascular diseases which cause retinal ischemia can be ocular or systemic. The most common ocular vascular diseases causing retinal ischemia are central retinal vein occlusion and diabetic retinopathy, each of which contribute to at least one-third of neovascular glaucoma cases. And this is very important to remember. Other retinal vascular diseases such as branch retinal vein occlusion, central retinal arterial occlusion, Coats disease, sickle cell retinopathy, retinopathy of prematurity, and occlusive vasculitis can all lead to significant retinal ischemia causing neovascularization of the anterior segment. And among the occlusive retinal vascular diseases, incidence of neovascular glaucoma after central retinal venous occlusion is much higher than the risk of neovascular glaucoma following central retinal arterial occlusion, branch retinal venous occlusion, and branch retinal arterial occlusion. And following central retinal venous occlusion, neovascular glaucoma typically occurs 8 to 15 weeks later, and so it is called the 90-day glaucoma. Systemic vascular diseases which can cause retinal ischemia and neovascular glaucoma include carotid occlusive disease. And even after angle neovascularization due to carotid occlusive disease, intraocular pressure may not be elevated because of ciliary body ischemia. Other more uncommon causes of glaucoma include inflammation such as following chronic uveitis and endophthalmitis, ocular tumors such as melanoma, retinoblastoma, lymphoma, and metastatic carcinoma following radiation therapy which causes radiation retinopathy after chronic retinal detachment and or retinoschisis, and anterior segment ischemia. So ischemia of the anterior segment can also cause anterior segment neovascularization. Other forms of significant glaucoma can also lead to neovascular glaucoma because significant glaucoma of any form can lead to central retinal venous occlusion, for which glaucoma is a risk factor. And this central retinal venous occlusion leads to neovascular glaucoma as we have discussed, and this is important to remember. Ocular surgery in a predisposed individual with retinal ischemia can precipitate anterior segment neovascularization, and this usually occurs following pars plana vitrectomy or disruption of the posterior capsule during or after cataract surgery. And this is because following these events, the angiogenic factors arising from the retinal ischemic areas have easier access to the anterior segment. And the pathogenesis of neovascular glaucoma can be described in 3 stages. In stage 1, neovascularization develops most commonly in the pupillary margin of the iris. And at this stage, although the new vessels on the iris are visible, since the angle is not blocked, the intraocular pressure remains normal. In stage 2, there is secondary open angle glaucoma when this fibrovascular membrane migrates over the iris across the angle over the trabecular meshwork up to the Schwalbe's line. So although the angle is clinically open on gonioscopy, the intraocular pressure can be raised because this membrane over the trabecular meshwork can block aqueous outflow, and gonioscopy at this stage will also show angle neovascularization. In stage 3 of neovascular glaucoma, characteristic angle closure glaucoma develops as the fibrovascular membrane in the angle contracts and pulls the peripheral iris forwards against the trabecular meshwork, blocking aqueous outflow. So the intraocular pressure will be elevated, and because of the development of this peripheral anterior synechia, the angle will appear to be clinically closed on gonioscopy. This neovascular membrane also pulls the posterior pigment epithelium of the iris around the pupillary margin onto the anterior surface of the iris, which appears as ectropion UV. Patients with neovascular glaucoma have blurring of vision both because of the retinal ischemia and the glaucoma, and they can present with an acute onset of pain and redness when there is sudden severe elevation of the intraocular pressure. Early in the disease process, iris new vessels can be detected most commonly in the pupillary margin, and from there on, these new vessels then extend across the iris towards the angle. The new vessels on the iris appears delicate, lacy and randomly oriented, and they may be difficult to detect in heavily pigmented iris. Later on, ectropion UV develops as seen here in this photograph, and the iris may appear smoother, the pupil may appear to be dilated and pulled anteriorly away from the lens. And the intraocular pressure in patients with well-established neovascular glaucoma is usually significantly elevated. Often it is this ectropion UV which leads us to suspect neovascularization of the iris, and on closer examination we then detect the new vessels on the iris. But ectropion UV occurs late in the disease process, and we can only save an eye with neovascular glaucoma if we are able to detect the neovascularization on the iris much earlier in the disease process. Patients with neovascular glaucoma may also have conjunctival and ciliary congestion, microcystic corneal edema, anterior chamber reaction as seen here in this photograph, and hyphema. Gonioscopy in an eye with neovascular glaucoma shows angle neovascularization early on, followed by development of peripheral anterior synechia. In the angle, normal blood vessels are either radial to the iris or circumferential along the ciliary body face, but they are all central or medial to the scleral spur. An abnormal blood vessels of angle neovascularization crosses anteriorly across the ciliary body and the scleral spur as single vascular trunks, as shown here in this diagram, and then arborize over the trabecular meshwork. And in lightly pigmented eyes, we will find the characteristic red flush of the anterior portion of the trabecular meshwork following angle neovascularization. So in this photograph we see these new vessels crossing anteriorly across the scleral spur and then arborizing over the trabecular meshwork. Gonioscopy in later stages of the disease process shows peripheral anterior synechia, and peripheral anterior synechia of neovascular glaucoma are typically broad as shown in this photograph, but they do not extend anterior to the Schwalbe's line because the fibrovascular membrane of neovascular glaucoma does not extend onto the corneal endothelium. So peripheral anterior synechia of neovascular glaucoma are typically not detected on slit lamp examination without gonioscopy, and this is in contrast to peripheral anterior synechia of iridocorneal endothelial syndrome, which typically extends onto the corneal endothelium and thus can be detected on slit lamp examination without gonioscopy. Relevant investigations in neovascular glaucoma include fluorescent angiography of fundus and the anterior segment to detect retinal ischemia, as well as to detect posterior and anterior segment neovascularization, especially in early stages when they are liable to be missed clinically. And in CRVO patients, electroretinography can identify those patients likely to develop iris neovascularization, and it has been seen that on bright flash dark adapted electroretinography, a B wave to A wave amplitude ratio of less than 1 increases the likelihood of neovascular glaucoma, as the B wave represents the inner retinal layers supplied by the retinal circulation, and the A wave represents the photoreceptor layer supplied by the choroidal circulation. Because of the extremely poor prognosis of well-established neovascular glaucoma, Early diagnosis of neovascularization and its aggressive treatment is essential to preserve vision and eye. And routine screening for iris and angle neovascularization before pupillary dilatation is mandatory in eyes predisposed to neovascularization, such as those with proliferative diabetic retinopathy and central retinal vein occlusion. And this is very important to remember. Management of iris and angle neovascularization and neovascular glaucoma is aimed at reducing neovascularization, controlling intraocular pressure, and providing comfort to a painful blind eye. Reducing the neovascularization reduces sequelae of neovascularization, such as raised intraocular pressure and failure of filtration surgery. And neovascularization can be controlled in the majority of patients with neovascular glaucoma who have retinal ischemia with pan-retinal photocoagulation and/or anti-VEGF injections. Pan-retinal photocoagulation is the more definitive way to control neovascularization, but it requires a clear media. By ablating the ischemic retina, pan-retinal photocoagulation reduces secretion of the angiogenic factors from the ischemic retina and thus reduce retinal, iris and angle neovascularization. And by controlling neovascularization, pan-retinal photocoagulation and/or anti-VEGF injections can reduce or normalize intraocular pressure, provided peripheral anterior synechia is not extensive and involves less than 270 degrees of the anterior chamber angle. And it has been seen that anti-VEGF injection can control neovascularization and intraocular pressure as early as 48 hours after injection, but the effect lasts only for several weeks following a single injection. And anti-VEGFs are often used as an adjunct to PRP and as a single agent when hazy ocular media precludes PRP. Pan-retinal cryotherapy in eyes with hazy ocular media is an option but is rarely employed nowadays because of significant risk of complications. Although pan-retinal photocoagulation is not able to control IOP in eyes with synechial closure of the entire anterior chamber angle, pan-retinal photocoagulation, if possible, is still recommended prior to filtering surgery because that reduces intraoperative hemorrhage during filtering surgery and reduces failure rate of the filtering surgical procedure. And in addition to ocular treatment with PRP and anti-VEGF, treatment of causative systemic diseases such as carotid occlusive disease can also control neovascularization. And it has been shown that during pars plana vitrectomy, which is a risk factor for inducing neovascularization of the iris and the angle, injection of intravitreal triamcinolone or silicone oil reduces the risk of iris or angle neovascularization following the procedure. In addition to controlling neovascularization, the elevated intraocular pressure has to be reduced, and this can be attempted with ocular hypotensives such as beta blockers, alpha 2 agonists, and carbonic anhydrase inhibitors. But the ability of medical management to control intraocular pressure long term in well established neovascular glaucoma is limited. And prostaglandin analogs and myotics are contraindicated in neovascular glaucoma because both are said to be pro-inflammatory. And as we have discussed in the previous session, myotics are not able to improve aqueous outflow in eyes with secondary angle closure glaucoma. And eyes with neovascular glaucoma often require steroids and cycloplegics to control inflammation. Filtering surgery by trabeculectomy or aqueous drainage devices can also be employed to control intraocular pressure in neovascular glaucoma, and the success rate of the surgery increases with reduction of intraoperative hemorrhage and postoperative inflammation if surgery is preceded by pan-retinal photocoagulation and/or anti-VEGF injection, and this is very important to remember. And several studies have shown that the most common cause of loss of vision after filtering surgery in neovascular glaucoma is progression of underlying retinopathy and not uncontrolled intraocular pressure. Transcleral cyclophotocoagulation can be attempted to control intraocular pressure in neovascular glaucoma when filtering surgery either fails or cannot be performed. eyes with poor potential for vision and with intractable pain can be made comfortable with cyclocryotherapy, retrobulbar alcohol injection, and enucleation. Prognosis of well-established neovascular glaucoma is extremely poor, with painful blind eye, severely elevated intraocular pressure, and bullous keratopathy. And as we have discussed, routine screening for iris and angle neovascularization before pupillary dilatation is mandatory in eyes predisposed to neovascularization, particularly those with proliferative diabetic retinopathy and central retinal vein occlusion. And we must also note that angle neovascularization can precede iris neovascularization in these patients, so gonioscopy is recommended routinely in these patients. And systemic control of underlying conditions such as diabetes and hypertension is also recommended. The other entity which causes secondary angle closure glaucoma by a predominantly anterior pulling mechanism is epithelial and fibrous ingrowth. Following surgery or trauma, when there is an inadequately closed wound, epithelial or fibrous tissue from the external surface of the eye or from the limbal or corneal stroma can gain entry into the anterior segment through this inadequately closed wound. And then this membrane goes over the corneal endothelium, the angle, and the anterior iris surface, contracts, and ultimately leads to secondary angle closure glaucoma by an anterior pulling mechanism. But because of improved closure of wounds following trauma or surgery under microsurgical control, epithelial and fibrous ingrowths are rarely seen nowadays. Risk factors for epithelial and fibrous ingrowths include wound dehiscence, vitreous incarceration in the wound, prolonged intraocular inflammation, hypotony with choroidal effusion, decimates membrane detachment, and decimate stripping endothelial keratoplasty. Decimates membrane detachment is specifically associated with fibrous ingrowth, and decimate stripping endothelial keratoplasty is associated with epithelial ingrowth. Epithelial ingrowths appear as thin translucent grayish membrane with a thickened scalloped advancing edge as shown here in this photograph. There can be edema of the overlying cornea, peripheral anterior synechia, and ectropion uveitis formation. The membrane consists of non-keratinized stratified squamous epithelium resembling conjunctiva over an avascular layer of subepithelial connective tissue, and application of green laser on the affected portion of the iris produces a white burn, and this enables diagnosis of this entity and assessment of the extent of involvement of the iris with this membrane. If diagnosis is still uncertain, cytology of aqueous chamber tap may help to identify the epithelial cells. Treatment of epithelial ingrowth is difficult and prognosis is very guarded. Removal of the membrane involves excision of the membrane along with the affected tissues and meticulous closure of the wound. And glaucoma associated with this condition can be controlled with aqueous drainage devices or cyclodestruction. Fibrous ingrowth is more common than epithelial ingrowth but is less aggressive and is often self-limited. It appears as an opaque grayish-white vascular membrane with irregular borders as shown here in this photograph. And the membrane consists of fibrovascular tissue originating either from corneal or limbal stroma within the wound or from conjunctival subepithelial connective tissue. And a break in the decimates membrane and endothelium is said to be the hallmark of this lesion, which allows growth of the fibrovascular tissue inside the anterior chamber. Treatment of fibrous ingrowth is control of intraocular pressure with aqueous drainage devices or cyclodestruction. To recap the salient points, neovascular glaucoma causes secondary angle closure by an anterior pulling mechanism. A fibrovascular membrane develops over the iris and extends over the angle, following which there can be a phase of raised intraocular pressure with clinically open angles, but ultimately synechial angle closure develops. The common pathogenetic factor for neovascularization are angiogenic factors, particularly VEGF, arising particularly from areas of retinal ischemia. And common entities leading to neovascular glaucoma include central retinal vein occlusion, proliferative diabetic retinopathy, and carotid occlusive disease. Patients with neovascular glaucoma present with blurring of vision with or without pain and redness. Early clinical features include iris and angle neovascularization. Later intraocular pressure increases, peripheral anterior synechia and ectropion UV develop. Corneal edema and anterior chamber reaction can also be present. Because of the extremely poor prognosis of neovascular glaucoma, careful examination for iris and angle neovascularization with pupils undilated in patients with predisposing conditions such as proliferative diabetic retinopathy and central retinal vein occlusion is recommended at every visit, and treatment should be initiated promptly when these new vessels are detected. Treatment to reduce neovascularization is laser photocoagulation of the ischemic retina, which is able to lower intraocular pressure when extent of peripheral anterior synechia is less than 270 degrees of the anterior chamber angle. This can be augmented with or substituted by anti-VEGF. And compared to panretinal photocoagulation, efficacy of anti-VEGF to reduce neovascularization is prompt but short-lasting. When peripheral anterior synechia extends more than 270 degrees, panretinal photocoagulation and or anti-VEGF is not effective in reducing intraocular pressure. However, panretinal photocoagulation is still indicated in this situation prior to filtering surgery because panretinal photocoagulation in this scenario reduces the risk of intraoperative hemorrhage and postoperative failure to control intraocular pressure. Medical treatment to lower intraocular pressure is not usually successful in the long term in neovascular glaucoma. Myotics and prostaglandin analogs should be avoided, and steroids and cycloplegics are often required to control the associated inflammation. Filtering surgery can be attempted with trabeculectomy with antimetabolites or with aqueous drainage devices, but prior panretinal photocoagulation and anti-VEGF injections are highly recommended. When filtering surgery does not work, transscleral cyclophotocoagulation can be attempted. And in painful eyes with poor visual potential, when the above options are not applicable or do not work, comfort can be given to the patient with cyclocryotherapy, retrobulbar alcohol injection, or enucleation. Epithelial and fibrous ingrowths occur in the presence of poorly closed wounds following surgery or trauma. Both can develop over the iris, angle, and corneal endothelium and result in secondary angle closure glaucoma by an anterior pulling mechanism which results in peripheral anterior synechia. Epithelial ingrowths are aggressive in nature and appear as a translucent layer on the corneal endothelium with a thickened scalloped advancing edge. Application of green laser on the area of the iris affected with the ingrowth results in white burns which enable us to diagnose the condition. Fibrous ingrowths are self-limiting in nature and appear as an opaque fibrovascular layer in the corneal endothelium and extending over the anterior chamber angle and the iris. Treatment of epithelial and fibrous ingrowths are difficult, requiring excision of the affected tissues, and usually has a poor prognosis. Thank you for listening.